everybody. Thank you for attending our mini Zoom symposium here. And before we start, I just want to give a special thanks to our partners at Hope and Heal, who were the funders of our original in-person symposium, which we're really hoping is going to happen later this summer, and also to Assembly Member Mark Berman, who sponsored the bill that made this project happen. And I also want to give a big thanks to all of you who came today and who plan to come up to Sacramento this week, but things have changed. I know this is a really busy time for everybody in healthcare. There's a lot else going on, and our attention's being pulled a lot of ways. So thanks for making the time to join us just to hear a little bit about our Bullet Points Curriculum Development Project. We have a list of about 30 people who were invited to this symposium. Many of you, one of us in our group has worked with before or personally. Others are friends of friends, collaborators of collaborators, and some of you actually found through extensive Google stalking. You're all chosen because you have some interest or stake in education and public health in your organization or your institution. And a lot of you are actually putting together firearm injury prevention curricula of your own. We reached out to you because with our project, which you'll hear a little bit more about later, we want to make sure that you all have the best resources available in a really easily accessible format for your providers. And we also want some help from you. We want to hear from you what it is that the people you are working with, the clinicians who are providing care to your patients, what it is that they know, what it is that they need, and what it is they will use to talk to patients about firearm injury prevention. We'll talk about that a little more later. A little quick intro to me. So I am Amy Barnhorst. I'm a psychiatrist here at UC Davis, and I'm directing the Bullet Points Project. When the Sandy Hook shooting happened, I was running a crisis unit and for psychiatry, and I also had 2 kids in elementary school. And so like so many moms, I was completely freaked out about sending my kids to school. And like so many psychiatrists, I was really frustrated by the burden and the blame put on the mental health system as a way to prevent firearm violence. So I got really interested in policy around firearm violence prevention and violence and suicide and mental illness. And I started writing and teaching a lot about this, and I really got involved with Garen Wintemute, who you'll hear more about, and his the now UC Firearm Violence Research Center. In my previous life, I was an educator, and I wasn't a traditional classroom teacher, but I lived in Yosemite, and I taught high school and adult students about the geology and ecology and native history of the park. So I did a lot of team-based curriculum development and thinking about novel ways to deliver that curriculum since we didn't have a classroom. We were outside on backpack trips and ski trips. And I found that when I went to medical school, medical education was really different, but there was a lot of opportunity to use some of those skills to deliver content to medical students and to practicing physicians. And it's really exciting for me to get back to this team-based approach of curriculum development. It's also really exciting to work with the team here at the Bullet Points Project. You'll meet some of them later, and I'm going to have them introduce themselves individually. They're all off camera right now. But they're physicians, researchers, and educators who all have subject matter expertise and a really great creative energy that makes this project really fun to work on with them. Most of us here in the e-audience, as you are, have counseled suicidal patients, treated gunshot wounds, or dealt with the long-term physical and psychological damage of firearm injuries. But it's not just a medical problem. This is a societal problem, it's a cultural problem, it's a political problem, and that makes it a public health problem. As physicians, we've always been on the front lines of intervening in public health problems. Things like cigarette smoking, things like motor vehicle accidents, to name a few. And it's our job to help patients stay healthy and safe and keep their families healthy and safe with up-to-date evidence-based information on what they can do. Surveys show that in general, doctors think it's within their purview to counsel patients about firearm injury prevention. And for the most part, patients are agreeable to hearing this information from a well-informed source that they trust, like their physician. But for a variety of reasons, most doctors don't engage in these discussions, even when they think they should. And this topic remains largely absent from medical school and other training curriculum. A little over a year ago, Assembly Member Mark Berman approached Garen Wintemute, who directs the UC Firearm Center, and he asked what he could do as a policymaker to help reduce firearm injury and death in our state. So Garen enlisted some other members of his team, And we helped draft up a bill that drew on research about physicians' perceived role in preventing firearm injury prevention and how patients react to these discussions and what the best practices were. Our language of the proposal was then incorporated into Assembly Bill 521, and it passed with bipartisan support last year. And the 2019-2020 state budget included $3.85 million for a 3-year project to teach medical and mental health professionals around the state how to counsel patients on firearm injury prevention. That then grew into what we are today, the BulletPoints Project. Our goals for this project, there's 4 of them that I'm going to talk about. And one is to determine what room is there for this in the medical education curriculum. There's so much to teach in medical school and also for nursing school and other medical and mental health professionals. So how do we reach providers in practice? How do we reach learning medical students without, taking over a bunch of the very busy curriculum already? How can we best insert and incorporate this material into what's already existing? We also, for our second goal, we really want to determine what kinds of educational modules are most useful and can actually be inserted into existing templates for learning. So as examples, do we best approach this topic by making small, standardized patient interview modules so that people can use them in doctoring-like cases? Do we make a series of lectures for an existing public health or an epidemiology course? Do we set up online CME for physicians in practice, create a podcast, make TikToks? What is it that is best going to reach our audience here? Number 3 is the to develop the content itself. And this is, what is it that folks need to know to counsel patients appropriately about preventing firearm injury in a clinical setting? So some of the content that our project is going to include, which you'll get a glimpse of today in the upcoming speed talks from members of our team. We're going to cover the epidemiology of firearm injuries and deaths. We're going to talk about state and federal policy that prohibits or restricts people's ability to purchase or own guns. Eventually, our project will include a Guns 101 class where people can learn about what is the difference between a rifle and a shotgun. What does a semi-automatic weapon mean? We'll talk about best practices for how to approach these topics with patients. What language can you use that's not alienating? What language should you not use? How do you counsel patients about safe storage? So what is the actual content of what people need to know? And then the 4th goal is to evaluate how we're doing. So part of what we'll be doing is rigorous contemporaneous evaluation of this project. And that's going to be really hard to show, for example, that our curriculum development actually decreased firearm injuries or deaths across the state, because there's so many things that factor into those rates. But a couple of things we can look at are how effective have we been at reaching our audience, how many people have done trainings with us or attended one of our talks or used some of our modules that we put out there. Have people changed their practices after looking at some of our educational materials? And how are patients feeling about the approach that we're teaching providers? In terms of our values and how we think of ourselves in our approach here, one of the main ones is that we are evidence and science-based. So you'll notice in a lot of our presentations, we use very neutral terms like firearm injury prevention, and we avoid more loaded terms like gun control. Because ultimately, we really want to not alienate our target audience. Even though we're teaching clinicians how to have these discussions, our target audience, because it's their target audience, are their patients who are firearm owners. And those are the people that we're ultimately trying to reach. Another one of our values is patient care. This is a very clinically facing project. We really want to give people tools who are providing clinical care. So even though a lot of the members of our team do research and do a lot of work with policymakers to advise on legislation, the focus of this project in particular is education about clinical care. And then the 3rd value that I just want to mention is respect for people's cultures and viewpoints. We really want to be able to bridge a gap between our views and our patients' views at all times in whatever kind of clinical encounter, but it's particularly important in something as loaded as firearm ownership. And so being able to have respectful, understanding discussions with patients where we can take our own political views or our own personal feelings out of it and really present them with the science and the evidence behind what can be best for them and their families. So what we're going to do today, since this is a very abbreviated version of the symposium we were planning to have in person, We want to give you guys a brief overview of the project, which hopefully you got a little bit from what I just talked about, and you'll get a little bit more from speed talks from members of our team. They're going to come up and go through a quick 5-minute presentation each on people's various areas of expertise in firearm injury prevention and how to talk to patients about these matters. And a lot of this information will be expanded on the website and incorporated into some of the modules that we develop. The talks today are going to cover the epidemiology of firearm injury prevention, some of the policies aimed at prohibiting folks from owning firearms, particularly as they pertain to mental illness, how doctors should best talk to and approach patient encounters about these discussions, the concept of cultural humility when you're talking to a patient from a different background or with different beliefs from your own, hospital-based intervention programs and what role they can play, and then how we evaluate a program like this. And at the end of the speed talks, there will be time for Q&A. We may end up going over the noon time, so if people want to stay and submit questions after that, we'll be around, but everyone else feel free to go because I know everyone's very busy right now. Your questions will best be approached by chat, so Ramisha, one of our team members, will be monitoring the chat questions that come through and making a list, and then we'll have everybody available to respond to those questions at the end in a more organized fashion. So with that, I'm going to turn it over to our first speed talk from Garen Winsmute. Thank you.
Hi, everybody. So I go by Garen. Amy's given me enough intro for speed talk purposes. I work shifts over the weekend. It's busy here. It's busy where you guys are. We're going to look briefly at the epidemiology, and Ramisha's going to queue up some slides. I'm not going to talk about the content of these slides so much. You all know this material, and you're going to have access to the slides. Basically, I'm just going to present the slides to you as soon as that option is available to me. And I'm running from here.
Should be.
There we go. Now I am. Great. So again, I'm just going to present the images to you. We all know about the struggle to portray violence as a health problem. Many of us use this quote from David Satcher, which he gave this to the New York Times just as he was becoming head of CDC. I don't need to repeat those words. This has worked well for audiences for quite some time. The reason things are as different as they are these days, we all think, is because of mass shootings. This happens to be a photograph of Aurora, Colorado, but it could be of any of those "it can't happen here" kinds of places where these things do happen. You all know the rest of the story. The nation's attention is riveted on these events, but we all know that they account for less than 1% of mortality from firearm violence. So let's come back to all those people. We have brand new data. CDC released its 2018 numbers just a couple weeks ago. I'm not going to go through these numbers. You'll have them. I'll just point out as a matter of presentation, I have another version of this slide that has Arlington in the background, the cemetery, which I use as a reminder to point out to people that in any 10-year period you care to define recently, we have had more civilian deaths from firearm violence than we had military fatalities in World War II. We could fill in Arlington to its current capacity with civilians in about 11 years. It doesn't have to be that way. You've all seen this comparison of motor vehicle traffic deaths and deaths from firearm violence. It's worth reminding people of the difference in approaches and the obvious difference in results. We now have firearm violence, deaths from firearm violence exceeding those from motor vehicle traffic collisions. It's also worth reminding people that firearm violence is not just about interpersonal violence, that a majority of deaths from firearm violence are suicide. We'll dive into this a little bit further until the increase just recently in firearm homicide, which appears now to have leveled off in just the last year. Firearm suicide was outpacing firearm homicide by 2 to 1. To look at a bit more detail, I have just lost my clicker. Can you advance for me? Thanks. Firearm homicide for men by race ethnicity for the most recent year we have available. You are familiar with this image even if you've never seen it. It's the one that shows the truly remarkable, awful concentration of risk for firearm homicide among young men, in particular, young African-American men. I'll point out that 20-some years ago, that y-axis topped out not at 100, but at 160. Terrible as this is, it represents an improvement. Here is suicide, which, however, looks quite different. Rates up early, essentially leveling off for African American and Hispanic men, increasing for white non-Hispanic men over time, not declining, and then increasing even more rapidly. I will circle back to this image in just a moment, but let me first show you the plots for women. We're looking here at homicide, similarities, rates highest among African American women. Note the change in the y-axis. We did top out at 100. Now we top out at 12. As a rough rule of thumb, on an age, race, sex-specific basis, divide the rate for men by 8 to 10, and you get the rate for women. But the image on the screen is fundamentally similar. For suicide, again, similarities and differences. The y-axis before topped out at 50, this one tops out at 6. But here what you see, obviously, is that while white non-Hispanic women are at greatest risk goes down after the mid-50s. It doesn't continue upward as it does for men. Now, here we are combining homicide and suicide. We're back to looking just at men. About 90% of deaths among men are homicide. So these are the African American men, I beg your pardon. So this is the curve for homicide plus about 10% for suicide. It looks basically the same. About 90% of deaths among white non-Hispanic men are suicide. So this is that earlier suicide curve plus 10%. It's been made horizontal by the much steeper rise for African American men. Everything I've done so far embodies a traditional risk-based public health approach. There are denominators to these things. We are looking at rates. But if we take a population-based approach and look at burden and not risk, things look quite different. I'll show you that on the next slide. The only math involved is to take the denominator away and go from deaths per 100,000 to simply deaths. So this is risk, this is burden. I'm going to go back to risk and forward to burden again. The visual message is obvious. Briefly, beginning at age 30 to 34, or 35 to 39 rather, a plurality of deaths from firearm violence, if we use that expansive definition, are among white non-Hispanic men. The relative increase obviously grows over time. The longer version of this talk develops this theme a little bit and ends with the question, so who knew that firearm violence was so much an old white guy problem? We'll talk about the implications for policy and policymakers another time. This is my last slide. We're looking at kids. I just want to make this point. For about 12 to 13 years, nothing happens. We really need, I would argue, to take better advantage of the opportunity that absence of anything happening provides us. And I'll stop there.
Okay, I'm back. Thanks, Garen. I'm going to talk a little bit about firearm violence, suicide, and firearm policy. As I said, I'm a psychiatrist, and part of how I got involved with this was after a mass shooting where, as usual, we saw the media very quickly jump to this presumptive association between mental illness, madness, delusions, and mass shooters. We see this over and over again. And it's really based on a number of assumptions, most of which are false, which are that people who threaten or commit mass shootings are mentally ill. And also that people who threaten or complete suicide are also mentally ill. Many people also believe that folks with mental illness can't buy guns, so that this shouldn't happen because the mental health system should have found them and prevented them from owning guns in the first place. And they would be able to do that because people with mental illness must be on some list somewhere, and everybody who buys a gun has to go through this background check and have their name cross-checked with that magical list. And also the assumption that we have this great system that works really well. Well, it turns out that even though mass shootings are what bring a lot of attention to the issue of firearm fatalities, as Garen said earlier, about 2/3 of firearm fatalities each year, and this is again 2018 data, are actually firearm suicides. So mass shootings represent that tiny, almost invisible sliver of white at the top of the graph, and the suicides are blue. Suicides do have a closer association with mental illness than homicide, even mass shooting homicide. But even the association between suicides and mental illness is suspect. The majority of folks who complete suicide don't have a diagnosis at the time of their death, as is the case for the majority of people who commit mass shootings. But in our country, there's an issue of how these folks have access to guns. And this began with the Second Amendment to our Constitution, which reads, as many of you know, a well-regulated militia being necessary to the security of a free state, the right of the people to keep and bear arms shall not be infringed. And this right went totally uninfringed until about 1968 when JFK was assassinated by a man who mail-ordered a rifle to his P.O. box. And people started to think, maybe we should put some legislation in place. And the Gun Control Act was passed, which is the biggest piece of legislation that regulates the firearm industry and its owners. And it prohibits firearm ownership at a federal level by prohibited persons, which include felons, people who are addicted to controlled substances, people who have domestic violence restraining orders filed against them, and most relevant for the mental illness discussion, folks who have been adjudicated as a mental defective, not my favorite term, but that's what the law says, or committed to a mental institution. So in some ways, the Gun Control Act was very prescient in that they understood that people who had committed violent crime or threatened violent crime in the past or had substance use problems were at higher risk of violence. But the association between serious mental illness and violence is again much looser. And the criteria for adjudicated as a mental defective or committed to a mental institution actually capture a small number of people. Adjudicated as a mental defective means you've been found incompetent to stand trial or not guilty by reason of insanity. And committed to a mental institution also means you have to have some sort of hearing before a judge or a hearing officer. So this is not just anybody who's been put on a 5150, anybody who's been in the ER or a crisis unit. You actually have to get admitted to a hospital and have your certification hearing before you're prohibited from owning a firearm. The Gun Control Act didn't give us a lot of guidance as to how we should communicate about these people. And it took another presidential assassination attempt of Ronald Reagan for his press secretary who was injured in it to pass the Brady Act of 1993 and develop what's now known as the NICS system, or the National Instant Criminal Background Check System. The NICS system is a centralized database run by the FBI whereby states are supposed to upload and report on information they have about prohibited persons. So each state is supposed to go through their criminal court records, their family court records, their civil commitment court records, get them all organized and upload them to the federal database. This is the 90s. So you can imagine that there are a lot of problems with collating all that information, figuring out exactly who meets prohibitory criteria, and getting it up on your rickety internet that you have. Not to mention there were a lot of concerns about HIPAA, and also states were not required, and still aren't, to upload this information. Yes, they're incentivized, but it's not required. California actually has some state-level prohibitions that apply to folks that are more stringent than federal prohibitions. And states are allowed to pass their own laws, which actually can create another problem for the NICS database, since our list of prohibited people don't match up with the federal list. Here in California, if you're admitted to a psychiatric hospital for dangerousness, you're prohibited from owning a firearm for 5 years, whereby the federal standard, you would have to actually be committed. If you're subject to a terrorist off warning, which is when a patient makes a threat specifically to a psychotherapist of violence towards an identifiable individual, that therapist is required to report to the police, and that person is prohibited from owning a firearm for 5 years. We also prohibit people who are convicted of violent misdemeanors here again, because prior violence is a big risk factor for future violence. In California, we have some other policies that are more stringent than the federal policies. We do have universal background checks, where every sale and transfer, even if private, has to go through the background check system. We have a purchase waiting period. We recently raised the minimum age for purchase, so now it's for both long guns and handguns to be 21. And we have limitations on how many firearms you can purchase within a given period of time. We also have unique tools that we were on the forefront of: extreme risk protection orders, or red flag orders. In California, this is known as a gun violence restraining order, where a family member or a law enforcement officer can petition for a person to have their firearms removed and have them be prohibited from purchasing new ones if there's a belief that they're at high risk of homicide or suicide in the near future. We also have the Armed Prohibited Persons program, where folks who previously were legal firearm owners and then had a prohibiting event but still now own firearms illegally, this team can go out and recover the firearms that are in their possession. So our project will expand on some of these topics further, and I'm going to turn it over to Rob Papillon, our education director.
Hi, I'm Rocco. I am directing the education component for the BulletPoints Project, and I'm going to talk a little bit today about physicians and firearms, things that we do know, things we don't know, and what kinds of components we plan to include in the BulletPoints curriculum to make physicians more comfortable and more confident in talking about firearms with at-risk patients. So we do know that deaths from firearms are preventable, and we also know that there are identifiable risk factors for firearm-related harm. Physicians have overwhelmingly said that they feel it's within their clinical responsibilities to assess risk for firearm injury and counsel patients who are at increased risk on ways to reduce that risk. And we know that patients say these conversations are generally appropriate. That includes people who own firearms, and specifically in California, survey research has shown that owners and non-owners alike find these conversations appropriate, and they're much more likely to say that conversations are appropriate when a person has access to a firearm and one of several risk factors is present. But physicians often report that they need more information about a whole lot of things in order to have these conversations with patients who are at risk. There are certainly barriers to these conversations. Among those barriers are legal considerations, so whether or not providers believe it's legal for them to speak with patients about firearm access. There are discrepant policies between states, particularly confusion about federal policies on a whole bunch of things related to firearms that may be serving as barriers to these conversations. Then there's also concern for alienating patients, concern about bringing a topic that may be seen as politically charged into the exam room. And then, as I said before, there are gaps in knowledge. That means knowledge of firearms, types of firearms, uses for firearms, reasons that people own firearms. Then there's gaps in knowledge about risk and who is at risk and who's at risk for what kinds of firearm injury, and what kinds of recommendations providers can and should make to patients. So the approach that we're going to take here is capitalizing on the unique potential that physicians and other healthcare providers have for talking with patients about the risks of access to firearms when someone particularly is at increased risk. So we want to promote the idea that assessing risk happens and that counseling is risk-based and informed by the evidence and by expert recommendation where the evidence is lacking. We also want these conversations to be tailored to the individual so that patients are engaging in conversations with providers about potential interventions that work for the patient and effectively reduce risk. So we started a couple of years ago, we started this work by developing the What You Can Do initiative, which was sort of a one-size-fits-all tool for teaching providers about who's at risk for firearm injury and how to talk with patients about firearm access and reducing risk, and also potential interventions for emergency situations. Now with bullet points, we have the capacity to expand that training and knowledge and information into a more comprehensive curriculum that we can disseminate and evaluate and improve upon. And that is something that can be specialty specific and patient specific and specific to the type of risk that patients face. The message overall, as I said, is to reduce access to firearms for those who are at increased risk. So what does informed and acceptable and individualized conversation about firearms entail? First, it's important that this is put in context, and that's the context of safety. And remember that trust is important in these conversations. So insofar as there are ways to engage with trusted people, family members, or other trusted people around the patient to help with this kind of counseling, that's important. We want people to know what safe storage means, and that safe storage looks different for different people, but increasing safe storage does reduce the risk of injury. It's important that providers understand that there is appropriate language to use. For example, the words temporary and voluntary when we're talking about potentially storing firearms outside of the home. Providers should be aware of policies and tools, federal policies and state policies, things that may affect the recommendations that you can make. And then it's also important that recommendations are reasonable and acceptable to the patient and ultimately doable. And then finally, know the gaps in your own knowledge and know when referrals should be made or when you need to ask others for advice on this kind of material. So there are a lot of questions that the Bullet Points Project is asking and will hopefully begin answering in the next few months and for a couple of years down the line. Those include things like, what sorts of facilitators and impediments are there to talking about firearms? And what about changing storage behaviors and limiting access in emergencies? What makes screening and interventions most effective? How can we engage with trusted people and family members for people who are at risk to increase the effectiveness of this kind of counseling and ultimately change storage behaviors? We want to know how providers can become more trusted messengers and how providers and our team can collaborate with owners and communities on how to prevent firearm injury. We want to make sure that we're learning how to better understand and approach this with people who come from different backgrounds and how we can change the conversation to reduce firearm injury. And now I'm going to pass it to Kara, who is going to go into detail on some of this stuff.
Thanks, Rocco. Hi, everyone. My name is Dr. Kara Tolles. I am an assistant clinical professor of emergency medicine and the director of equity and inclusion in the Department of Emergency Medicine here at UC Davis. And today I'm going to be talking to you about cultural humility in patient interactions. So some of the concepts that we're going to explore in this short 5 minutes are concepts of culture, cultural humility, and bias, so that we can hopefully improve our ability to have culturally humble, non-judgmental communication with patients in general, but especially around gun violence. So the big picture question that we're going to explore is how to not alienate patients who come from backgrounds that are different than yourself, especially around this topic of gun violence. So the first question that we have to explore is what constitutes culture? And the short answer to that is it's very complicated. So there are many different things that fall under culture: body type, age, race, immigration status, guns, all sorts of things, gender, sex. So firstly, culture is complicated, very important thing to know. And then I want to introduce to you this idea of cultural competence really being a fallacy. We're talking about how complicated culture is, and move you more toward the framework of cultural humility. So this idea of competence meaning a mastery of a finite body of knowledge. We just talked about how culture can be quite complicated, especially if you think about the intersections of those social identities and things that constitute culture. So So let's move more toward this framework of cultural humility, which per Dr. Tervalin and Murray Garcia, who's actually here at UC Davis in the School of Nursing, cultural humility, it requires a lifelong commitment to self-evaluation, self-critique, and then redressing the inherent power imbalances in the patient-physician dynamic. And this doesn't have to be patient-physician, it could be patient-provider. And it also, cultural humility also requires meaningful partnership with communities. Per Dr. Fisher-Bourne, cultural humility requires acknowledgement of both individual and systemic forces that negatively impact marginalized communities. So thinking about some of those systemic forces, this is a little bit of a busy slide, but I'll direct you to the left side of the slide there. If we think about especially marginalized communities, what are some of those systemic forces that are shaping the experience of those folks? All sorts of isms, so racism, classism, ageism, etc. And then also thinking about how these things can intersect if people are a part of many different oppressed social groups. So how the experience of a white working class gay man might be different than a white affluent gay man, just for an example. So moving down into the individual level, we think about this concept of bias. So bias, what is it? These are positive or negative attitudes that a person holds toward another person, group, or thing. And then there are two different flavors of bias. So there's explicit bias, it's conscious, we know about it, and then the implicit bias. These attitudes and beliefs that are unconscious, that lie below the surface, they're actually part of our biology and evolution. They can help us adapt. It's essentially what happens when we go into autopilot when we're stressed or we're tired. It's good to know that they can also be irrational and harmful, and that we all have them. So this picture of an iceberg is kind of a visual representation that is commonly used to show that up above the surface are those explicit biases that we all have, and then beneath the surface are those implicit biases that can also play a very big role in how we interact and communicate with one another, especially folks who are different than us. So again, big picture is to answer and explore this question about how not to alienate patients who are different than us, especially around a topic that can be very emotional and maybe tap into some of those implicit biases that we explored. So in summary, culture is complicated, especially with regard to guns. Understanding that there are individual biases that play into our interactions with one another is critical. Understanding those big picture systems of oppression which impact especially marginalized communities is very important. And then thinking more about this framework of cultural humility as opposed to cultural competence being the goal, and realizing that it's likely a lifelong process which requires a lot of self-critique, but also meaningful partnership with the affected communities. Thank you.
Hi everyone, I'm Nicole Kravitz-Wirtz. I'm an assistant professor in the Violence Prevention Research Program in the Department of Emergency Medicine here at UC Davis. And today I'm going to very briefly dive into hospital-based violence intervention programs, or HVIPs. So to start, just a little bit of background. Exposure to violence, particularly interpersonal, community-based violence, is a recognized form of trauma. And when people are hurt, they're more likely to hurt other people. Research has found that among the strongest predictors of future violent injury is a previous violent injury. In communities highly impacted by violence, 5-year rates of injury recidivism as high as 45% have been reported. HVIPs aim to disrupt the cycle of violence by not only supporting recovery from physical wounds, but also by addressing the upstream or social determinants of violence. So just a few principles of HVIPs. Life-saving medical care, HVIPs operate from a public health approach, recognizing that life-saving medical care is critical but life-saving medical care alone is not sufficient for supporting recovery or preventing repeat violent injury. Because standard medical care often does not provide violence prevention services that address the conditions that put people at risk of violence in the first place. HVIPs operate from the premise that there is a unique window of opportunity to disrupt the cycle of violence that starts at the hospital bedside following a violent injury. Research suggests that in the immediate aftermath of violence, individuals may be particularly receptive to making changes in their lives and altering behaviors to prevent future harm. And while individuals may be particularly receptive to altering life trajectories, healthcare providers may not always be the most effective messengers. However, healthcare providers can facilitate connections to trained violence intervention specialists who, in the case of hospital-based programs, are hospital staff, but who more importantly are credible members of the communities they serve and often share lived experiences that help facilitate their ability to provide relationship-based mentoring and intensive individualized case management services to victims of violence. Here I just want to walk quickly through through a typical HVIP process. First, a victim of violence, so someone who has been assaulted, stabbed, or shot, is admitted to the trauma center and treated. Although this is not a typical role for violence intervention specialists, they may make contact with the family of the patient or the next of kin to facilitate the transmission of information from the hospital to the family. More often, and ideally now, this is often done by trained, specialized, community-based crisis response teams. So once the patient has been stabilized, the violence intervention specialist locates them, usually through EMR or referral from other hospital staff, and proceeds to visit them at the bedside to begin the process of establishing rapport. Now, this is often not a one-time event and requires multiple visits to establish a basic sense of trust. Remember, these are individuals who have just experienced trauma, both physical and psychological, and the systems in which they've interacted with in the past often have failed them or their communities, including the healthcare system. So if the violence intervention specialist is able to establish this basic sense of trust and rapport with the patient, they are able to offer the patient enrollment in the program, and then the patient is also potentially consented into participating in research or evaluation. At this time, an initial needs assessment is also often completed. When the patient is discharged, the violence intervention specialist typically provides 6 to 12 or more months of post-discharge programming and case management to address the patient's evolving needs and to support longer-term healing and to address any of their longer-term goals. And the ultimate sort of goal here is to quote-unquote advance patients from one-on-one supports through the violence intervention specialist to existing natural and community-based supports in their community to facilitate ongoing healing and violence prevention. So just to narrow in here on what that post-discharge programming and transition to community-based supports looks like, it's in short specific to the individual, but in general it often involves the violence intervention shepherding clients to a number of services in the community, including mental health services, job training, employment and educational opportunities, substance abuse treatment, securing stable housing, obtaining victim of crime assistance, court advocacy, among many others. Now, the evidence on HVIPs is still developing, but evaluations of individual programs have demonstrated success in addressing risk factors for violence among their clients, including obtaining mental health services, as well as obtaining employment or helping them return to school, increased self-esteem, changing attitudes towards guns and violence, decreasing trauma or injury, recidivism, and studies have also found substantial hospital cost savings associated with HVIPs. However, there's a critical need for additional multi-site studies over longer time periods, as well as the need to incorporate not only quantitative metrics, but also qualitative assessments of HVIP process, impacts, and outcomes. And I encourage those who are interested in more information to visit the Health Alliance for Violence Intervention or the Hobby for more information. Thank you.
Hi everyone. So like HVIPs, bullet points will also be an interesting project to try to evaluate. I'm Amanda Charbonneau. I'm currently a postdoctoral fellow at the Violence Prevention Research Program here at UC Davis. And for the Bullet Points Project, I am leading the research and evaluation efforts. So that work falls broadly into 4 categories. The first is looking to identify gaps in education on firearm injury prevention. And I want to thank all of you for participating in the survey that we circulated. That is one piece of the needs assessment, and it's really going to help guide our efforts going forward. The second category is tied primarily to dissemination. So we're going to track things like the number and types of providers that we reach. And the third category is looking at trying to gather as much information as we can on the effectiveness of bullet points. And so we'll be looking at things like increasing knowledge and changing practices among both providers and patients. And related to this work, the LA County Department of Public Health is planning to conduct a health impact assessment. And they will be mapping the pathway between bullet points and population level decreases in firearm injuries and identifying potential gaps along that causal pathway. So Will Nicholas and his team may be reaching out to folks as they put together an advisory group for some of that work. So finally, we will also be developing tools to assist providers in identifying patients at risk and intervening as appropriate. And some of that research will rely on electronic medical record data. So I mentioned the needs assessment survey, and I just want to present a couple of very high-level results from that. So of the 25 of you who responded, 7 are aware of existing firearm injury prevention education at your institution or organization. Of those 7, most are optional, and they either occur online or as part of a class on a broader topic. Some are grand rounds. So given that finding, it's perhaps not surprising that when we asked you what materials would be most useful, you rated all of them as very useful on average. So there's not a ton of variation here, but I have listed these in order based on the average ranking that you provided for these materials. And as we're developing these, we're going to be looking in more detail at the results of the survey. So if you haven't had a chance, we would still love your input. You can still log into that survey and weigh in on this. And so you also left comments that to me suggest that you're very engaged on this topic, and if you haven't already taken action, you are very much ready to do so. So for that, I want to thank you, and I'll leave you with one of the comments from the survey.
And that last slide, which will be in the recording, the last slide, which will be in the recording, has the emails of our group if folks want to reach out individually to any of the presenters. And I just want to say, just watching these mini presentations, I'm really excited to work with this team. And there's such an incredible body of knowledge here, and there's so many more topics we can do talks on, and it's going to be really cool once this is all wrapped up and put in one place. So we'll talk a little bit about what's going to be next for us. We are shifting strategy a little bit since we weren't able to meet all of you in person and get more information at the symposium. But we're going to really start, rather than taking in what some of the needs assessment information we were hoping to gather in person, we're going to start working on developing some of our materials and then maybe reaching out to folks individually. So we have a website in production, which many of you may have visited already. You may have also noticed our very spiffy logo and our branded PowerPoint presentation. Oh, hang on. And also my mug. One of our big goals is that we want clinicians, when they're in a patient encounter in a high-risk situation or in a position where they need to be counseling people about firearm safety, to not think, oh gosh, who were those people that came and talked to me and how do I find their information again? We wanted to be at the forefront of their heads. So one of the things we did was to engage a really awesome digital design team who helped us with some logo development, some branding, and the website. And so we really want to get this symbol out there, which is very small and hard to see. And we have, for example, mugs available for those of you symposium invitees who want to email the bullet points, email the HS-bullet points that is on your invite emails, and send us your mailing address and we will get you a mug. We're also going to have stickers and pins and whatever it takes to get people to have us at the forefront of their minds in a busy clinical encounter so they know exactly where to go quickly to get the information they need. So we're going to work on, in the next few weeks, really next few months, years perhaps, and really fleshing out the information on the website, creating the modules that people have requested, having talking points for physicians who talk to media, having epidemiologic slides that people who are teaching public health courses can incorporate into their lectures, and then also just being a go-to resource, both for a quick clinical encounter where you just need to know what tools are available to you, and also having a resource library of peer-reviewed journal articles for a much deeper dive. What's next for all of you is hopefully an in-person symposium over the next couple months when the coronavirus dies down a bit and things hopefully return to normalcy. So stay tuned for another date. I actually got an email this morning that they had closed the venue we were planning to hold this at anyway. So we'll see when they reopen, and we're going to try to get it all back together because we were really excited to meet all of you in person and hear about your experiences and your needs. We may be reaching out to folks individually, as many of you have specific knowledge or experience within a certain type of system in terms of what you've been doing and what you would like to be doing. And we have gotten a few questions through the chat. So I want to thank everybody who took time for coming. And if you can stick around, I'll field some of these questions with the other members of the team. And if not, send us your mailing address for one of our limited edition mugs. And we're really excited to have your involvement and your input in the BulletPoints Project also. And we really think this is something that can make a difference in California for medical and mental health care providers. So thank you for being here. And now Ramisha's going to feed me some questions. Just read. Okay. Let me read them. Okay. So one of the questions I got is promotion of hospital-based intervention programs one of the goals of BulletPoints? Seems important, but encompasses more than training of clinicians. For example, involves non-clinical staff and has cost implications for the hospital. Yes, absolutely. And we're not, it's not within the scope of BulletPoints to actually train clinicians how to set up an HVIP and execute it at their hospital. It's more within the scope of BulletPoints to say, hey, your hospital might have this, and you should consider it a tool or a resource that is available to you. Like, for example, an involuntary psychiatric hold, it's a tool that may be available in certain situations to certain types of providers that people need to be aware of. But it's beyond the scope of us to teach you how to actually set one up and run them. Will curriculum development attempt to focus on screening and counseling interventions for which there is already evidence of effects on behavioral outcomes? This may be limited, given the evidence is limited, but seems like a good place to start. So yes, as much as possible, we are going to focus on screening, counseling interventions that have an evidence base. And it's true that there's a limited body of evidence about this, but Rocco has worked really hard on the What You Can Do project, which is a website that physicians can go to see what is the evidence for certain kinds of counseling, what kinds of interventions are available, and what is the research behind them. So yes, we will very much have an evidence-based focus. That's it for questions. If you have other questions about the project, please feel free to reach out to us. You all have my personal email. You all also have the HS Bullet Points email, which is our just shared email box. And thanks for being part of this really exciting project. And thanks to this great team for getting all this together. Oh, and go to our website, which has the splash page up, which is
BulletPointsProject.org.
BulletPointsProject.org. I just wanted to make sure I had that one right. So it's BulletPointsProject.org. You can see what the website is going to look like. We just have the first page up at this point. There will be lots more on there in the future, including a recording of this presentation. Thank you, everybody.